Good afternoon, ladies and gentlemen. Today we're talking about two separate topics. One is the occurrence of heavy menstrual bleeding that occurs frequently in women over the age of 30 to 35 and is associated in a large number of cases with uterine myomas or fibroids. This type of problem I consider to be not vigorously investigated for several reasons. One, it only occurs monthly. Two, it only is bothersome in impacting on the quality of life or work productivity for 3 to 4 days each month. Three, these women usually don't see a physician because we don't have an adequate medical treatment. And four, it is easily cured by having a hysterectomy performed. So heavy menstrual bleeding is really of unknown etiology. For many cases, it is associated with uterine fibroids or pelvic endometriosis. The problem that I see is that we have some treatments now that are reasonably effective medically. We do not have to resort to a surgical intervention such as an endometrial ablation or a hysterectomy. These treatments are the levonorgestrel releasing intrauterine device, combination oral contraceptives, and tranexamic acid, each of which has a relative efficacy ranging from 50 to about 90%. If one uses the intrauterine device, you get both contraception and treatment interventions concurrently. It reduces the scheduled bleeding on a regular period very quickly, but it does increase the incidence of unscheduled uterine bleeding in these women. Combination oral contraceptives, on the other hand, estradiol valerate dienogest, is the one that is approved in the United States, significantly reduces menstrual blood loss rapidly, has a contraceptive action. And lastly, tranexamic acid, which is not contraceptive, used during menstruation, will reduce the actual blood loss to below 80 milliliters per ml, a normal range, in about 50 to 60% of the women. The problem that I see for many women is the duration of the contraceptive product, and many women do not want to use it. However, I can tell you that it appears to definitely improve the quality of life and the work productivity. And my argument is, although we don't understand totally the etiology of the heavy bleeding, it would be important to use a medical therapy prior to a surgical approach because it reduces the morbidity and the low but definite mortality from these procedures. The second discussion I had today had to do with unscheduled bleeding, whether it's by using a combination hormonal contraceptive, a progestin-only method such as an injectable or an implant, or the use of continuous combined hormone therapy in postmenopausal women. I believe that this all has the same underlying etiology, basically a fragility of the small microvessels underlying the epithelial lining of the uterus. In this case, we're not sure of exactly what the sequence of events is, but I believe there is a local inflammation, followed by an activation of proteases that dissolve the collagen ground substance that supports the blood vessel and the stromal cells in the endometrium. And ultimately, the blood vessel breaks down, causing a release of blood, and that blood then has to be taken through the lining of the uterus, which is also broken down, for us to see visible bleeding. I have no good reason for telling you what causes it. I only know it is associated with the use of progestin therapy. In our current studies, we have shown that women who are hypertensive and under treatment with hypertensive medication and are postmenopausal have an increased incidence of spotting and bleeding while using continuous combined hormone therapy. If they were on a beta blocker or a angiotensin II receptor inhibitor antagonist, they reduce significantly the breakthrough bleeding, spotting, and bleeding. For these reasons, I believe that we are treating something in the endometrium that is associated with the renin-angiotensin-aldosterone system. Although I have no direct data, the implication from other studies in contraceptive using women who are taking drospirenone only suggests that there is a reduction in unscheduled spotting and bleeding in a group of women who have risk factors such as high blood pressure or obesity. How this plays out will only be known in the next several years. At the present time, there is no good treatment for the spotting and bleeding as well, as far as I'm concerned. So I give you the expectation of success and keep following this program for further information. Thank you very much.